we're going to talk about chronic kidney disease with regard to the NICE guidelines update. So here we go with the PowerPoint slides. Now, this new guideline has revolutionized many understandings, many management plans for future management in the NHS. We'll discuss the changes which the NICE guideline has now introduced. Prior to a couple of months ago, there were 3 different NICE guidelines about chronic kidney disease in respect of iron treatment, how it should be managed in adults and in children. This is now all consolidated into one. So this is how I would describe chronic kidney disease, which is a reduction of the kidney functions or intrinsic damage present for 3 months, characterized by either increased creatinine in the urine, and so it would be reducing eGFR, estimated glomerular filtration rate, and increasing albumin creatinine ratio. And much of it is produced through urea and electrolyte disturbance. So how does one diagnose the chronic kidney disease? Well, generally, you talk about chronic kidney disease when the eGFR has diminished from 60. And previously, NICE guideline had agreed to adjust the estimated glomerular filtration rate, giving regard to ethnicity. And it has now come to accept that in the Afro-Caribbean people and also people of Southeast Asian origin, there are changes in its statistical BMI. So African Caribbean individuals may be tall and have a larger muscle mass, whereas the Southeast Asian lady could be a lady with central obesity and poor muscle mass. So this now is calculated using the kidney failure risk equation, which gives regard only to age, sex, eGFR, and ACR, and has no regard to ethnicity. So if there's been a persistent reduction of eGFR of less than 60 milliliters per minute in an average-bodied man, then this constitutes a diagnosis of chronic kidney disease, CKD. Similarly, if the urinary albumin creatinine ratio exceeds 3 milligrams per millimole, then that constitutes chronic kidney disease as well. There are other parameters under which chronic kidney disease can be assessed, and these would be dipstick urine test, which could record presence of red blood cells, indicating that there could be hematuria, and therefore one should investigate for one should investigate for cancer, and preponderance of white blood cells on microscopy, which would suggest possibilities of pyelonephritis. And so cellular fatty or granular casts could indicate presence of a structural autoimmune disease of the kidneys. So there is a condition called accelerated progression of CKD, which means that during the monitoring phase, if the eGFR has decreased by more than 25%, or if there's a change in the CKD category within 12 months, then we should regard this as a form which will soon be heading towards CKD5. So what could be causes or risk factors associated with CKD? We know that some systemic illnesses such as hypertension, diabetes can result in structural and functional damage to the kidneys. So these are interlinked. And so these conditions cause CKD, and CKD promotes these conditions. So glomerular filtration diseases such as acute glomerulonephritis will also produce CKD. There are other aspects as well. Past history of AKI, acute kidney injury, use of nephrotoxic drugs such as aminoglycoside, which means streptomycin, neomycin, gentamicin, ACE inhibitors such as ramipril or lisinopril, angiotensin receptor blockers such as losartan, candesartan, and so on, bisphosphonates, which are for bone protection, such as alendronic acid, fosamax, and zoledronic acid, calcineurin inhibitors such as cyclosporine, antimetabolite, and antifungal, and tacrolimus, which has a multipurpose use. Old-fashioned diuretics, particularly of thiazide group, such as benroflumetazide, benrofluazide, and indapamide, mental health medications including lithium and mesalazine for colitis, and NSAID, non-steroidal anti-inflammatory drugs such as ibuprofen, Nurofen, Voltaren, and naproxen could all cause nephrotoxicity and therefore induce CKD. Obstructive neuropathy such as benign prostatic obstruction, malignant obstructions, urinary diversion surgery, multiple calculi in the urological tract causing obstruction can also lead on eventually to CKD. And there are multi-system diseases which have renal involvement as well, such as systemic lupus erythematosus, multiple myeloma, and vasculitis. If a person has a family history of CKD stage 5 or a congenital condition such as polycystic kidney disease or Alport syndrome, then they are more prone to developing CKD. Persistent, untreated, or unmanaged cardiovascular disease such as ischemic heart disease, congestive cardiac failure, peripheral arterial disease are also linked amongst the causative reasons for CKD. Obesity with metabolic syndrome is linked to it, remembering that metabolic syndrome is characterized by mnemonics of HIDO, hypertension, insulin resistance, dyslipidemia, and central obesity. So how does CKD affect the National Health Service? So various ethnic groups and people belonging to different socio-economic classes are affected differently. A new study involving about 130,000 patients recording in the primary care of EGFR readings alone with read coding discovered that there was a collective 8.5% risk of CKD in the general population, with prevalence more often in women. But under the new guidelines and using 400 group practices in the UK under the NHS, NICE suggests that the estimate of incidence is overall 13%, in the UK adult population for chronic kidney disease of CKD 3, 4, and 5. One must bear in mind that age has a significant bearing. And so the older the person, the worse the prognosis of CKD. What are the complications of CKD? Firstly, it can lead on to acute kidney injury or accelerated kidney progression. It can cause hypertension. It can worsen dyslipidemia. It can worsen or cause cardiovascular disease, such as inducing ischemic heart disease, peripheral heart disease, and stroke. And again, reminding that people with CKD are 5 to 10 times more likely to die prematurely than other people, and they are less likely to die from end-stage renal disease. So CKD kills through cardiovascular risks, and that this is an exponential risk. One deals with features and complications of CKD, reminding again that we are now talking about stage 3, 4, and 5. The renal anemia often seen means that the hemoglobin is less than 11 grams, and that this is usually due to reduced production of erythropoietin. Although the kidney is injured functionally, yet it does not produce enough erythropoietin. In addition, the limited amount of erythropoietin that is secreted results in fast reproduction of red blood cells, but the red blood cells do not survive for the expected 120 days and die within 4 or 5 days. So in a slide, one would see the same amount of RBCs as one would see in a patient without CKD, but in CKD, most of these cells would be immature, early erythrocytes. An important complication of CKD is renal disease causing mineral and bone disorders. And it does that in a variety of ways. It reduces the uptake of serum calcium. It could be high initially with vitamin D deficiency. And of course, by inverse relationship, there would be raised serum phosphate. And so this goes on to be allowing us to mop up the phosphate through phosphate binders. Other complications of CKD include neuropathy. So that this would mean sleep disturbances, anxiety, and restless leg syndrome, akathisia, and pains on the long muscles, such as spine. Because of its digestive involvement, there would be features of malnutrition. And this is commonly seen in the end-stage renal disease. And this is due to dietary poor intake and hypoalbuminemia. Some malignancies are linked to CKD, such as malignancies of renal tract as well as thyroid. End-stage renal disease can progress from stage 4 to stage 5, when it may necessitate renal replacement therapy. Now, what would be the prognosis of CKD? So with the decreasing EGFR or increasing albuminuria, there is poor prognosis for the patient. And some researchers have shown as high as nearly 15% people have died from all-cause mortality with presence of CKD. And yet, very few percentage of CKD patients progress on to end-stage renal disease, requiring renal replacement treatment. So who ends up with end-stage renal disease? So someone who has had an accelerated progression of CKD, and people do not survive long enough to have end-stage renal disease with CKD of an advanced stage, and they then therefore die because of cardiovascular and other complicating mortalities. How do we undertake basic investigations in the primary care? You do full blood count, measuring hemoglobin, checking up on ferritin, and also looking at various cell counts such as RBCs and WBC count. You could undertake vitamin B12 studies as well in the full blood count. There would be urea and electrolyte, basically assessing for creatinine and also for estimated glomerular function, estimated glomerular filtration rate. LFT is done to look at various enzymes, dyslipidemia, and effects of CKD. Thyroid function tests to see the functional status, and of course, if needed, then parathormone and calcium and phosphate studies ought to be done. The albumin creatinine ratio requiring a abstention from eating red meat for 24 hours and collecting the first catch specimen of the morning, and then treating it, sending it quickly to the laboratory for albumin creatinine ratio. In addition, a dipstick test could be done for albumin and sediments, remembering that not all dipsticks are sensitive enough to calculate albumin, whereas they might be suitable for protein estimation, but not albumin. Albumin is a very small quantity of the protein in the urine. If there are features of major structural damage, suspicion of malignancy, or if there is uroobstruction, then ultrasound scan of both kidneys and the tracts would be necessary. In addition to undertaking these tests, it is important to give weight to prodromal symptoms as well. Sometimes clinical diagnosis precedes laboratory results. So the general symptoms are those of malaise and anhedonia, and of course, some of the symptoms of aches and pains match up with symptoms of chronic fatigue syndrome or similar conditions. The urine output is checked from patients' records kept by themselves as whether the patient has polyuria or has in fact reduced output of urine, suggesting nephritic element. Edema is linked to urinary output. Level of water intake in relation to dehydration or water loss can lead to acute kidney injury. Obstructive uropathy suggests possibilities of CKD. Of course, the history of nephrotoxic drugs, past history of AKI, or associated comorbidities will also point a finger towards chronic kidney disease. Some patients will outwardly show features of mental health disease such as anxiety or depression. Cognitive impairment is sometimes present in advancing stage of CKD, and MMSE will determine some of it. Reactive features such as tachypnea and hypertension are features that are found often with CKD. Of course, uroobstruction and malignancy or cysts can be found with physical examination of ballotable kidney or of the liver with cysts. Often patients complain of frothy urine, and this may indicate proteinuria. Albumin is too small in quantity to produce froth, but if this is substantive in nature, it can itself produce some froth. Bear in mind that in the early stages of CKD3, some patients are asymptomatic. And of course, the thing to remember is that you would diagnose CKD if the eGFR is less than 60 and or ACR is more than 3 milligrams for a period of 3 months. Therefore, on the first encounter, you will note it but not read code CKD. You will undertake remedial measures such as correction of comorbidities and also increasing the volume intake of water, and then reassess the patient in 6 to 12 weeks. And if the condition is unchanged, you will then recode the diagnosis of CKD according to the levels of eGFR and ACR. So what are these levels? This comes into the classification of CKD using the CGA system of National Kidney Foundation. So C stands for clinical evaluation, and G relates to eGFR, and A relates to albuminuria. So as you can see, that a normal person maybe at G0 may have an eGFR of around 100, but when we record G1 as not less than 90. So it could be more. G2 will go on to 60 to 90. It's G3 where the diagnosis of CKD is made, and CKD3A or G3A is when the eGFR is reduced from 60 to going backwards to 45. And CKD3B or G3B would be when it would be from 44 going down to 30. Similarly, CKD4 or G4 would be 15 to 29. And of course, less than 15 GFR would indicate the level of G5, at which stage the kidney failure would be diagnosed. Looking at the CGA method, one would see that albuminuria also can categorize. So A1 would be when ACR is less than 30, remembering that less than 3 is normal. So between 3 to 30 would be mild increase. And so A2 goes from 30 to 300 and A3 300 plus. We also mentioned that the classification relates to clinical aspect. So in the CGA system, the first part is C, which is the clinical one. So clinical evaluates whether a patient is suffering from a systemic disease with renal involvement producing CKD, or a patient is suffering from a primary disease of the kidney producing CKD. And these relate to functional elements anatomically, such as glomerular disease, tubulointerstitial disease, vascular disease, cysts, and congenital diseases. And so you could categorize these into many forms. The idea of classification is to be able to scientifically describe the stage that the patient is at. It would be comparable to the TNM classification of the old-fashioned breast cancer lump. How would one treat? And I'm coming towards nearly the end of our presentation. There's just one more slide to go. So the basic emphasis is in lifestyle changes. So smoking cessation, And of course, keeping the Poshka's cycle of change in mind, smoking cessation should be expertly introduced. This week's BMJ talks about a group of patients demanding e-cigarettes on prescriptions. So there are some of us who agree and there are some of us who disagree. Smoking cessation should be gradual to full total loss of smoking, not replacement of major smoking to minor smoking, because some of the bad effects of smoking are all or none. Patients are fully damaged with smoking, regardless of how little they smoke. Healthy, balanced diet would mean a plate portion of diet, 3 portion carbohydrate, fat, and protein, or 5, which has the other ones, plus also fiber and vitamins. So a balanced diet is more important than the old-fashioned low protein, low carbohydrate diet. Salt should be restricted. This is common salt to less than 1 teaspoonful, which is a measure of 6 grams. It is better to undertake regular exercises, accumulating 150 minutes a week, rather than to do drastic exercises for a few times. Alcohol limit is allowed to up to 14 units of alcohol a week, remembering that even a single unit of alcohol is harmful to the liver and the kidneys as well. Weight management should be achieved under an organized method. So Weight Watchers and also Lighter Life relate to small group exposures where people are criticized, people are rewarded, people are acknowledged, and therefore short-term goals and long-term goals are established in accordance with what the patient presents with regard to the weight. One should ensure that the patient understands that the over-the-counter NSAID, non-steroidal anti-inflammatory drugs such as ibuprofen, Brufen, or Nurofen, or Naproxen, or Voltaren are not used because they are quite badly nephrotoxic. This is the last slide. So of course, we would treat the comorbidities, and almost always there would be hypertension present. So we would use ACE inhibitor like ramipril, fosinopril, lisinopril, ARBs like losartan, candesartan, diuretic, more or less loop diuretic like furosemide, remembering that there is a potential of ACE inhibitor to induce worsening in people who have got peripheral arterial disease and have therefore possibly got renal artery stenosis, which gets worse. So after initiation, within 3 weeks, you must do urea and electrolytes to check to see if any worsening. If there's no worsening, we can upgrade the ACE inhibitor or ARBs to the maximum tolerable one to achieve the target. Statin would mean atorvastatin minimum at 20 milligrams per day. There should be an antiplatelet medication because of invariable and multiple risks of cardiovascular problems and cardiovascular worsening. And so aspirin is usually preferred. And if there is aspirin intolerance, then of course, clopidogrel would be a substitute. Seasonal vaccines should be offered because of vulnerability, such as pneumococcal vaccine and the flu vaccine. If the patient has edema as part of the CKD, the loop diuretic furosemide is good, but it should only be given when the eGFR is above 30. The anemia should be identified first as an iron deficiency anemia or low RBC count anemia, then which should be treated with an iron infusion or erythropoietin given on a weekly basis. Bone and calcium and phosphate are treated by avoiding phosphate, and therefore red meat, dairy products, eggs and fish are avoided, and phosphate binders are used, and vitamin D supplements are given in uh, places which are not um, known to be sunny. If there is glomerulonephritis, then obviously use of glucocorticoid, high dose steroid initially until improvement takes place, and then coming down to the minimum, maintaining a maintenance dose for 2 or 3 months, and then re-evaluating. Cyclophosphamide is given once in a week, and it is fairly fast acting, but with numerous complications, particularly nausea and vomiting, for which the best medication would be ondansetron. Dialysis as a form of renal replacement could be peritoneal or this would be um, hemology basis. Hemodialysis relates to radial artery and nearby vein fistula, when veins become arterialized and can sustain the high pressure of the dialysis machine. Hemodialysis also improves on removal of waste products, and it's usually done once a week, and machines can be provided to patients at home. So if patients go on holidays, then the destination is alerted, and so hemodialysis can be provided there. Peritoneal dialysis is self-performed on a nightly basis, on every night, and it is variable in terms of tolerance. Transplant of kidney is undertaken under the transplant protocol. Supportive treatment would mean offering advice on self-management, doing something, avoiding something, and leaflets, internet advice from Kidney Care UK would give such advices. I hope that you have benefited from this presentation. The idea is to allow the members of the audience to apply the knowledge to make good use in their clinical practice. Thank you for listening. Thank you. Bye-bye.